Okay, welcome back everyone. You can tear yourselves away from the bookshelves. Hope you've had a nice opportunity to have some lunch and chat to colleagues. It's always part of the good thing about these days, isn't it? Is the opportunity to catch up with people and meet new people who are working on similar areas. And heard lots of conversations, really stimulated by the two presentations we had this morning. So thank you very much. Elaine Edgar from the Department of Health has had to go now, but I think you'll agree that was a really helpful presentation, and I know she's very happy to stay in touch with people. And do take the opportunity when the consultation comes out around the regulations and guidance. I think it's going to be really important that we continue to try and influence that process as we get nearer to implementation. And then we had a great session from Mary, really kind of giving us a very good overview of some of the research literature, and a very helpful way of looking at that through two different paradigms. So we've got a packed afternoon ahead of us. And to start off, I'm delighted to welcome Diane, who's going to talk about informing service development through the analysis of survey data, improving carers' quality of life, ?
Thank you very much. Good afternoon. My name's Diane Fox, and I'm here with my colleagues, Theresia Baumker and Anne Netton, and I'm happy to...
Can I make the general volume of the speakers? There's a lot of soft furnishing in the room, it's absorbing a lot of the sound about it.
I'll speak up.
I know that's recording, but it's not amplifying.
I see. I'm delighted to be here to tell you about the work that we've been doing. Apologies for the lack of handouts. They will be available later on the website, but I know I can admit in an audience such as this, I have been balancing work and care this week with my temporarily sick toddler. So I'm sure you will understand. The main part of this presentation is about the analysis we did on the Personal Social Services Survey of Adult Carers in England. I know that's a mouthful and it's a long name, but I'll get to why it's called that later on. Most of our colleagues that work in councils will know it as the Carers Survey. So first I'd like to tell you about the survey and its development, so that you can get a bit of background, and then I'll move on to the main analysis. So the starting point is that in 2008, Kent County Council, with involvement of Sue Williams, who's here today, and the Department of Health, commissioned colleagues, Jaquetta Holder, Nick Smith and Anne, to develop a postal self-completion carers survey for use in Kent. The development had 4 stages. Firstly, there were some focus groups with carers, recruited via support groups, and also some group interviews with care managers. There was an appraisal of the existing research on carers' needs and outcomes, and those 2 stages fed into the design of some survey questions, which were then cognitively tested with a group of 25 carers. Cognitive interviewing is a technique used to test understanding of questions and response categories, the ease or difficulty of recalling information. So, for instance, if you're asking someone to think back 5 years ago, they're probably not going to remember. And to test out the relevance of the question topics for carers. So, as you can see, a lot of the process was rooted in carers' experiences and took into account their views, which addresses one of the weaknesses highlighted in this morning's presentation by Mary. So then, the sample was drawn from carers identified by social service records as having had an assessment or review in the last 12 months, carers named on the records of a service user who had had an assessment or review in the last 12 months, because as we know, a very small proportion of carers have an assessment in their own right. And also, to try and reach those hidden carers, we tried to identify carers by 18 voluntary organisations as well. And the broad topic areas covered a lot of the characteristics that Mary highlighted in her presentation before, which was structural things like the type of caring relationship, carers' characteristics, the characteristics of the cared for person, but also we looked at satisfaction with social services, impact of services on aspects of quality of life. They were separate things. We looked at quality of life separately, we looked at the impact of services separately, and aspects of service quality separately, but in the analysis we're going to try and look at the relationships between those things. So that was the first step in developing the PSS-SACE, or the Carer Survey, with the very long name. The Kent development happened in 2008, and it was just prior to the publication of the 2008 Carers Strategy, and because of the policy aims that outlined, the Department of Health funded the development of a carer survey for national use and to incorporate some of the policy aims in the strategy. So it was a programme of surveys of people using social care services are collected already by councils with adult social services responsibilities, and that programme of surveys is managed, collated and analysed by the Health and Social Care Information Centre, and there's a group, the Social Service Users Survey Group, which oversees the development of those surveys and steers the direction that they go in. So we had some input from Elaine in the steering group for this project as well, so we were aware of what was going to be happening in the next few months in terms of carers policy. Sorry, that was the slide you were supposed to be looking at there. And so the Personal Services Social Services Survey of Adult Social Carers in England, the PSS-SACE, or the Carer Survey, built upon the Kent Carer Survey, but there were some additional stages of development, some response analysis which led to question amendments. There was engagement with stakeholders to identify priority topic areas to include, and we consulted with Carers Trust, although it was Crossroads and Princess Royal Trust for Carers at that time, Carers UK, CQC, the Care Quality Commission, and new questions on carers' experiences of healthcare settings and whether they were supported by their employer were developed to add into the questionnaire. And those new questions and the amended questions were then tested again with 30 carers, which were identified from a local authority in the south and a carers voluntary organisation in the north. So then the SSUSG agreed the final questionnaire within the guidance of the Association of Directors of Adult Social Services, who get the final say. And they were a little concerned about burden, and there were a lot of questions, there were 58 questions, and because they were concerned about how much burden this would be placed on local authorities, some of the questions were optional and local authorities could decide whether to include them or not. Okay, so local authorities didn't have to run the survey, it was voluntary the first time round, and 90 out of the 152 local authorities in England took part, which was just over half, and there you go with the mandatory and optional questions, and that was sent out to carers who had undergone an assessment or review in the last 12 months, and also carers of service users who had an assessment or review in the last 12 months. But you'll notice that this time we weren't sending out to voluntary organisations because there were just too many of them and it wouldn't have been practical to do so. So that was sent to 88,000 carers and returned by over 35,000, which is a response rate of 40%, which for the length of the survey and the fact that carers are so busy, we felt was really good. So that brings me to the project that I want to talk to you about today. It was part of a collaborative project with our PSSRU colleagues from the LSE, And there is the disclaimer to say this is our ideas, it doesn't represent those by the School of Social Care Research, Department of Health, or the NHS, or the National Institute for Health Research. So I just quickly mention the work that our colleagues at LSE undertook. And this ties in a little bit with some of the things we were talking about this morning, about the visibility of carers. So, building on analysis carried out by the Health and Social Care Information Centre, Dr. Linda Pickard and Dr. Derek King compared the sample of carers who responded to the PSS SACE and carers completing the 2009-10 survey of carers in households. So this is why we've got such a long name for the survey, because they wanted to make sure there was no confusion, because they were both published at the same time. They were both analysed by Health and Social Care Information Centre. Reports about them were coming out at the same time. And of course, this survey is on only a subset of carers that have some link to social care services, whereas the household survey is a general population survey which is carried out by interview face-to-face in people's households, and so they are quite a different sample. And so, controlling for those differences, Linda and Derek have tried to identify characteristics of unpaid carers which are visible to councils and examine the variation between councils and the extent to which they are in contact with carers. I'm sure Linda will be happy to tell you more about that if you want to ask her. So the work that we were doing was looking at the variation in carers' quality of life, and so that's part of the work that the Kent team did to try and unpick some of the situational and structural factors mentioned by Mary this morning and how they have impact on quality of life. So we wanted to explore what's already known about influencing carers' quality of life, look at individual level factors of the carer and the cared for person, so their characteristics, but also the nature of the relationship, the caring relationship. And then look also at effects of the local area that people are living in. So we looked at factors accounting for variation at the level of the council or local authority. Sorry, wrong slide again, I'm behind. So we wondered whether carers living in a particular area would have similar scores on a quality of life scale, and if so, why that might be. So area characteristics such as average wage were built into the model. That was after undertaking a review of the literature and carrying out some initial analysis to look at the structure of the sample. So the multi-level modelling separates out individual factors and area factors, things like average health in that authority. And the scale we used was developed during the Kent Carers Survey work. Some of you might recognise 5 of the domains listed here because they're very similar to domains which are in the Adult Social Care Outcomes Toolkit for service users. And however, additional domains identified during the focus groups carried out in the Kent survey development work were also space and time to be yourself and encouragement and support in your caring role. So these were specifically, thanks Anne, I was on the wrong slide again. These are specifically carer generated domains. It was things that were important to them. Unfortunately, one ended up being an additional question just because of the survey length getting a bit too long, but they were collected by most of them were collected by all of the local authorities. It's just space and time to be yourself. Not all of them collected that one. Okay. So here's an example question. And you'll notice that there are 3 response options. and each of the domain had a question with 3 response options like this. The top one representing somebody that has no needs in this particular area. The middle one represents somebody who's got some low needs in this particular domain, and at the bottom one someone has high needs, and so that would be, if someone's ticking that, would be a bit more of a flag. Okay. So in the multi-level modelling, we included 6 of the 7 domains listed there. We had to exclude the one that was optional question and sum them together, and that made our quality of life scale. And the type of model took account of various things like the distribution of the quality of life measure, because some of the domains were more likely to be met than others. So we accounted for that, and the possibility that carers' experiences within a local authority might be more similar than those elsewhere. So, and obviously we took into account any factors identified in the literature that might have an influence. So there's the 2 levels of the model, and what we found was that most variation was associated with individual factors and not differences between local authority areas. So perhaps that would be unsurprising, seeing as carers are such a diverse group with different caring situations and different needs. So they are more different within an area than between different areas, sorry. So here we found these are significant associations with quality of life. So non-white ethnic background, which I know we were talking about a bit this morning, poor self-perceived health, caring for someone with dementia, living with a person with dementia, living with a cared for person, high intensity of caring in full-time employment, female, and aged under 65. I know that some of those might look like they go hand in hand, but we controlled for that effect and they were still independently significant. So this actually ties in with Mary's talk this morning, where she was talking about profiling carers and looking at the impact of caring. So it seems that carers with one or more of these characteristics are more likely to report poor quality of life. And so that feeds into the discussions earlier about carers not being a homogenous group. Some might be more at risk of poor quality of life than others. And so then it takes us to look at what is associated with good quality of life. So controlling for the effects of those things in the previous slide. The probability of reporting good quality of life increased with a positive experience of support or services. In particular, easy access and helpful information and advice, and easy access to services. That's where services can make a difference. Easy access is the key. And actually, I got a sense of this already anecdotally when I was doing the cognitive interviews, and time and again carers would say to me, it's so hard to get anything. We have to jump through hoops, and it's difficult to find information. So obviously these things are particularly key. There were some other factors which were significant, but to a slightly lesser extent than access and helpfulness of information and services. And that was not waiting for services for service user, contact with care manager, being better consulted about services for the service user, better timing of the services, so I suppose that feeds into flexibility, and being informed of any changes and being respectfully treated by the service provider. So the impact of these findings on policy and practice are, less importantly, through the SSUSG, the work will feed into decision making about future versions of the carers survey. I And I think alongside other research, these findings could contribute to the growing evidence base on the most effective ways to support carers. From 2012, there was a mandatory but shorter version of this survey, and it was sent by all local authorities in England, and 4 of the domains for the adult social care outcomes framework measures are derived from this. And in the future there will be a consultation led by the Health and Social Care Information Centre about the next version of the carer survey and when that will be run. So do get involved with that and comment. Now, I just wanted to talk to you a little bit about this last one, about helping to interpret quality of life and outcome measures contained within the PSSAs, which could support decision making and improve practice within local authorities. It kind of links in with another project I'm involved in, which you might have heard of. It's Maximising the Value of Survey Data in Adult Social Care, or the MAX project. And this is funded by Department of Health, QUORU, the Quality and Outcomes of Personal Centred Research Unit. And in partnership with local authority staff and providers, service users and carers, we are aiming to produce 2 toolkits, one for the Adult Social Care Survey and one for the PSSAs, to try and support the analysis and interpretation of results and the communication of survey findings. So we've just finished the fact-finding stage, which was an online survey and telephone interviews and a document analysis, and we're just writing up a report of that stage now. And the next stage for the next year is toolkit development, where we'll be running consultation panels with representatives from local authorities, service users, carers and providers, and with them, in a collaborative way, coming up with materials for a toolkit which would enable local authorities to analyse their survey data more effectively and make interpretations more easily. And so I'm hoping that the fact that we've done this analysis would serve as a basis from people to work, and will feed in and give them a national context. So then in the next year following that, the toolkit will be tested and disseminated. So we've been lucky enough to get an extension of funding from the School for Social Care Research to do some further analysis, because the work that we've done has just kind of thrown up more questions in a way. And so with the permission of the Health and Social Care Information Centre, who we have a data sharing agreement with, we're going to explore the relationship between satisfaction and carers' experiences of service quality, and explore in more detail the variation between different groups of carers, in particular different ethnic groups. And we're also going to look at a comparison of the data between 2009 and the 2012 surveys, which will give us some cross-sectional data and potentially be able to look at changes as a result of policy changes. So that kind of more longitudinal aspect that Mary spoke about this morning, hopefully, and that might give us some more information about that. So I put some links there to further information if you would like it, and I'd be very happy now to hear your thoughts and comments and take any questions.
Great, Diane, thank you very much indeed for that. Really, really interesting, I think, around the, particularly for me anyway, particularly the elements around what links to lower quality of life and what links to higher quality of life. Because I immediately started thinking, does that resonate with when I have conversations with carers about what they tell me? And I thought there were some quite interesting things there, particularly around the point about kind of easy access to services as well, and that issue around some of that is also recognition of the carer's role. You know, does the care manager give you time? are you treated respectfully? So some very important indicators there. It leaves another question: what does that mean then in terms of service response? Which I'd be very interested if anyone's got some thoughts on that. So those of you who are involved in running carer services maybe, or supporting carers, was there anything in there that particularly struck you that was helpful? But more generally, any comments that you'd like to make on the presentation, or any further questions? Who wants to start? We've got one there, then one there, then one there. So we start down here. Do you mind standing up and because I think it's a bit difficult to hear at the back. So if you just stand up and do it, that's great.
Diana Jones from Carers Lewisham, which is a Carers Trust partner. I just would like to know whether any mental health carers, because they tend to not come into social care type services, because in my experience, mental health caring is one of the most stressful and tricky situations, and dementia is one of the highest levels, and I can see that. It's quite common sense really, but mental health, I was just wondering how many mental health carers were invited to participate and to answer the questions.
Oh, I don't have those figures to hand. However, I know there were some mental health carers, albeit a fairly small cohort compared to older people, for instance. But yes, we did start to try and look at some differences, and that's something that we might look at actually, is carers of people with different conditions, and see how that is different. So some early analysis seem to suggest that they're having more difficulty in accessing services, but I suppose the way the services are structured are partly related to that. So yeah, I'm really interested in pursuing that particular area.
Okay, good.
Just a follow-up to that question really. I'm the head of social care within a mental health trust. So part of the work we were doing when the surveys were coming out last year within our county was to adapt the survey when it was sent out to mental health service carers, because we were aware that they understand they're receiving services, or the cared for person is receiving services from the mental health trust. If they got a survey from the local authority, they'd wonder what it was and
Yeah.
it to them. So we made sure we badged it jointly, and that was really effective, and then we had a really good response rate. And our results were really positive. What we found was the reverse of what you've described. And mental health carers described a much less negative, more positive, depends how you look at it, experience of receiving services that they've had.
That's very interesting.
Joint Health and Social Care Trust.
Yeah, I'm glad that you're badging it in that way, because one of the findings from the cognitive interviewing was that people don't always realise where their services are coming from, even if they originate as social services, because they're delivered through maybe a voluntary organisation or through health services. They wouldn't necessarily think of themselves as a social care service user or person they're looking after.
Okay, thank you for that.
So in 2008 one, I mean, you always think you're doing okay, but you never know really how you're doing. So we actually analysed the 2008 one, which was better. And one of the things that came up was internet information and advice to people. So we actually increased that substantially. And then when we had the 2009-10 survey, we were able to see there was a significant difference in the responses. So,
Right.
and we were able to see that of all the work we've done across all of those domains, they were significant. So I think it's a really crucial tool to be able to help. Admittedly, it's a randomised sample of carers. It's never going to be the same people. But I think at least it gives you some information. It's useful. I also should say that in that first carer survey, we had all the various carer user groups and carers on my advisory board, and they really did provide me work for us to account, didn't they? So I think, and we carried on to that.
That's a great example, both about involving people right at the beginning of the process to get that right, but also then how you learn from the results of the survey, and then able to put that into your service planning and delivery. That's fantastic. That's what you want, isn't it? As a researcher, is to see that impact. It's a really nice example. Thank you for that. Any other?
You may have given the answer in one of your previous answers, but I couldn't quite hear. Did you record the condition of the person that they cared for?
Yes, we did. Yeah.
So that's extractable data?
It is, and that's one of the types of analysis we probably do next, is to compare those groups. And actually you can get the data on the Health and Social Care Information Centre website if you want to have a bit of an analyse yourself. But yeah.
Okay, any other questions or comments for Diane? Yep, one here and then one at the back.
Okay, so I work in Bournemouth Borough Council. I'm just trying to mix the data that we were given by one of the previous presenters, where were you only aware of 13% of carers in the whole of the country? So this is a survey of 13% of carers.
Yeah.
So it's quite a small proportion of.
It is.
So it was just an observation of that.
Yeah, I'm glad that you raised that, actually, because of course this particular survey and the mechanism through which it's collected means that we're only looking at a very small subgroup of carers compared to the more population-based surveys like the census and the household survey that Linda and Derek worked on. And actually, if you look at their work, you can see the differences in the profiles of people that are captured by this survey and the people that are captured in the household survey, and look at those differences, and they're quite interesting.
Thank you.
Julian Leggett from Calvary County Council. Just be interested to know, do you routinely feed back to your respondents the impact of the views that they've expressed? And if so, how do you publicise that?
Question.
We don't, but individual local authorities, because they administer it from the local authority, they choose the degree to which they give feedback. I know that some have a summary on their website of the main findings. Some ask people to tick whether they would like a report sent to them. And so it varies the degree to which it's fed back. But actually that's one of the things that we're hoping the MAX project might address, is to try and find more effective ways to communicate findings back to service users and carers.
What do you do in your authority?
We use Opinion Suite, which is we asked, you said we did approaches on where the individual surveys, as we say, people can have their individual copy of their life, but whatever format they like. I was just intrigued to know how widespread.
Yeah, because it's really important. I mean, certainly one of the things sometimes that we get fed back is, sometimes carers can feel over-surveyed, but not feeling that they're seeing the impact of their experiences. And actually, if you're sharing your experience, it can be quite a personal thing, and actually it can be quite a difficult thing to do sometimes, because it can make you really think about your situation. And if your situation isn't positive, you're sort of left with that. So I think letting people know what the results were, what's happened as a result, is incredibly important.
Even if something hasn't happened.
Yeah, exactly. At least people know this is, and the information's being dealt with well. I think it is really, really important, isn't it?
Well, actually, yes, that's probably part of the reason why I put a question mark there.
Yeah.
Because although we found out what can impact on quality of life, some of that is nothing you can really do about, somebody's gender. However, there are those elements of services that can improve quality of life, but it's a matter of implementing the changes that are necessary. And so I think it's too early still yet to claim that results from this survey can have an impact on quality of life, but if individual authorities put programmes in motion as a result of the findings, then hopefully it will have an impact.
I suppose what could happen is that from this work better the interventions and the services that will help, but it doesn't necessarily mean that you have the resources to then do that. Yeah. So there is that sort of issue, isn't it, around the implementation. So we might learn more and know better, but we've still then got to have the will to make it happen, haven't we? Yeah. Okay. Any final thoughts or comments? Dan, thank you very much indeed. Okay. Now our next speaker is Wendy. Wendy's there. Yeah, thank you.